Okay.
Okay. Now Manjul can share his, the presentation about you.
Sure. So I think this is the time for the formal welcome and the invitation. And sorry for this initial technical hiccup. Sometimes they come, but I'm glad that we are able to share our screens now and we are through it. And welcome you all. Good afternoon, everyone. This is our first WFNS Radiosurgery webinar. And I think this has been a real transformation. And I'm so glad that for the first time, we have a speaker who has actually seen it from the very beginning. I am a neurosurgeon and radiosurgeon in India, and currently the chair with my co-chair, Professor Selçuk Peker, for the WFNS Radiosurgery section. And I request Professor Selçuk to introduce our esteemed speaker today, Professor Jeremy Ganz. So I'm sharing the screen for him, and Professor Selçuk has an honor of introducing Professor Jeremy Ganz today.
Thank you, Manjul. Can I see the PowerPoint presentation, please?
Yes. So,
Thank you. So, dear colleagues, it is my great pleasure and real honor to introduce Dr. Jeremy Ganz, a highly respected neurosurgeon and one of the distinguished figures in the history and development of gamma-knife radiosurgery. Dr. Ganz was educated at St. John's College, Cambridge, and St. Thomas Hospital Medical School in London, and his neurosurgical career has included appointments at leading institutions in the United Kingdom and Norway, including National Hospital, Queen's Square, Frenchy Hospital in Bristol, Manchester Royal Infirmary, and the University of Bergen. And he served as a consultant neurosurgeon in University of Bergen and become the director of the gamma-knife center there, and also after that he also served as the clinical director of the gamma-knife center in Cairo. And Dr. Ganz really loves to give education, and I am one of his pupils. I have an honor about it, and he visited a lot of centers to do startups in those centers. You see the list of the centers here, a lot of centers from everywhere in the world, and becoming one of the centers which we host him there. It's an honor for me. And he is also a prolific author with extensive publications in neurosurgery, radiosurgery, neurosurgical history, and multiple major books, including works on gamma-knife neurosurgery, history of gamma-knife, and a lot of history of cranial surgery, etc. So about these books, I read all of them about gamma-knife radiosurgery, I can say that, and I'm very happy to read all those books. And today we are privileged to hear from a surgeon, teacher, historian, and pioneer whose work has helped shape modern radiosurgery. So please, Dr. Jeremy Ganz, stage is yours. Thank you so much.
Thank you. You can hear me?
Yes, sir.
Okay. What I was proposing to do was not a PowerPoint presentation, but go through the question and answer document you sent me and tell you the answers. Is that acceptable?
Yes, sir, it's acceptable, sir. If you have a presentation, it's good. Otherwise, this is a question answer format, so it's good.
Yes, I wasn't asked for a presentation, and it's all been fairly quick, so I hope you accept this limited version. We'll start off. Question 1 is, why is it important for modern radiosurgeons to understand the history of radiosurgery? 2 points. Radiosurgery is a technique, not a profession. There are no radiosurgeons, only neurosurgeons who use radiosurgery. We do not refer to microsurgeons, it would make them look small. The second thing is, studying history illuminates the various technologies and their strengths and weaknesses. It also illustrates improvements in technology which lead to changes in opinion. Question 2. What were the essential components required for the development of radiosurgery as a discipline? The production of narrow, well collimated radiation beams. study of the radiation biology of the interaction between radiation and human tissue, study of the means of accurate delivery of the radiation to the desired location. How did this interaction between science, technology, and society influence the birth of radiosurgery? The gamma knife was originally designed to treat functional indications like thalamotomy for Parkinson's disease and central pain. From the earliest days, these became minor indications, not least with the limited referral of Parkinson following L-DOPA.
Professor Ganz, if may I interrupt a bit, is it possible for us to ask some questions as we sent, and then you can just answer those ones?
Oh, please do.
Please do. Yeah. And if you do not have a presentation, yeah. So the question was actually what we wanted to know is that apart from these three initial ones, the great questions, what aspects of the Lars Lexell's training and personality uniquely positioned him to pioneer the radiosurgery? You have been seeing so many of his colleagues, and there was a contemporary neurosurgery world. So what actually was with which particular aspect of the Lars Lexell's philosophy and personality which could change it?
The thing you have to understand, as I suspect you all know, is that in Sweden, doctors in universities have to have a PhD. They're allowed to work for 12 years, and during that time, they must get a PhD. Lexell was in this position, and his PhD was about the physiology of gamma motor neurons. His mentor was a physiologist, the point being that he was, at an early age, more familiar than most with the details of the intricacy of the structure of the brain and nervous system. Another thing that helped him, as a child, he was allowed to work in a metal workshop, which was later useful in later life for designing instruments. Not least, he lived at a social level which gave access to wealthy investors. His personality was genial but persistent, with an openness for new ideas. You see, I have a copy of a paper he wrote, and it's an absolute mess with it being constantly re-edited, changed, penciled, crossed out. He was always changing his mind.
So he, as you told, that he was continuously evolving, self-evolving himself. He was exposed to the open neurosurgery. He was in the same center probably where the great neurosurgeons, open neurosurgeons have worked. So what changed his philosophy looking at that contemporary time?
Oh, well, you have to remember at that time, his mentor was Oliver Kroner. And when he first asked Oliver Kroner, did he recommend a career in neurosurgery, Oliver Kroner said no. But he persisted, and he started out as what the Swedes call, it's a lovely term, dropper. He was the anaesthetist, and the term dropper was because the ether was dropped onto gauze. At his time, I mean, Oliver Kroner was about the best neurosurgeon around, and the operative mortality he brought down from 70% to 40%. And Lexell felt that this was unsatisfactory, and he wanted to develop systems that were less traumatic.
So this was going towards the minimum invasiveness in his time, but I think
basically think neurosurgery damaged and killed people. And with the technology available at the time, this was unavoidable. I mean, just to go off a slight side thing, it was accepted that a patient with almost no symptoms going for an acoustic surgery would almost certainly come out with a permanent total facial palsy. And this was accepted at that time. This is how bad it was back then.
And sorry. I think it's very important and very smart move to term something as a radiosurgery, to give it as a term. So anything, have you ever discussed how did this term radiosurgery come to his mind, being a neurosurgeon?
What he wrote in that paper in 1951, which is the most quoted paper in radiosurgical literature, a previously described stereotax, and he said stereotaxic, not stereotactic. stereotactic technique has now been used for direction of narrow beams of radiating energy to the target in the brain, and he then coined the term radiosurgery.
I think this was a very smart move to keep this technique in the realm of the neurosurgeons so that they can practice the radiation therapy with the surgical precision and on these patients of the neurosurgical patients. So this term, I consider it as a very smart move in his times. As you just told about the stereotaxy, so before the Laxell's innovation,
yes,
before the Laxell's innovations, what were the stereotactic techniques prior to the radiosurgery, and what limitations actually existed before that?
Well, the first stereotaxy was Horsley and Clark in Oxford, and their system was used for experimental work on animals. And as it was on animals, the precise localization of the lesion was not perhaps that vital as it would be in humans. And they had no map. So a lot of the time they were putting the lesion slightly in the wrong place. Spiegel and Weissis came with a similar stereotactic frame to the Horsley one. And the problem with that was Laxell went and saw it, and he didn't think much of it. He thought it was too clumsy and awkward to use. So what he did was, instead of using simple Cartesian, Cartesian axes, he added an arc to the frame, which made it much simpler to direct a rotating arc. So he could much more simply direct an instrument to the location he wished to reach. And in fact, that arc on a frame is basically the design of the gamma knife. It's the same set of principles.
So we are practically using that same principle still after some 7 decades of its origin.
Yes.
It's a very, very robust machine. So you must have seen the initial first cases. There is always a controversy. Which was the first case? Was it a craniopharyngioma or a trigeminal neuralgia? I find a history very conflicted.
Take this part further. There were a number of anecdotal cases. One was a woman with schizophrenia. There was one other I don't remember. There were 2 trigeminal neuralgia cases, and they were treated with very low doses, localizing on the skull X-ray, and they're probably the best results in history because they were pain-free for nearly 20 years, both of them. And in fact, they have very little to do with the subsequent development of gamma knife and its use in trigeminal neuralgia, because when they started using the gamma knife for trigeminal neuralgia, they injected some substance. I'm having a geriatric memory loss. Something they put in to show the location, and the pain relief from this substance meant that they stopped doing the gamma knife, and they went on. Hawkinson did a doctoral thesis on using chemically installed liquid into the appropriate area. So
it was glycerol plus tantalum, sir. Glycerol plus tantalum.
Yes.
Mm-hmm.
So the actual development of trigeminal neuralgia came somewhat later.
It's very interesting to know if that result is so good. Should we credit it to tantalum and the glycerol, as you just told, or to the radiosurgery? Because later on we completely moved from that place to the cisternal component of trigeminal nerve, and with such a high dose.
No, the 2 X-ray, the 2 cases treated with X-ray, forget them. How they worked, why they worked, it remains something of a mystery. But the initial glycerol, that's right, as you get old, you forget things. Glycerol was done by Hawkinson in preparation for a gamma knife. Laxell could be a little bit naughty, and it was done on the one day, and the treatment was delayed until the next day for social convenience. And when they came in to treat the patient was pain-free. So they stopped doing radiosurgery. And as I say, Hawkinson did his PhD on glycerol. And the subsequent development of trigeminal neuralgia came somewhat later.
Yeah, I think it should be credited again to Dr. Konziolka, because in the late 90s, he came with the new evidences in favor of the radiosurgery, but at a different target and with a different dose. And since then, we are just following that practice.
Well, also, I think we have to acknowledge Jean Régis has made an enormous contribution
Exactly.
to the way to treat it. But one or two things, actually. They talk about the dose, should it be at the front or at the back of the trigeminal nerve? Now, that actually is nonsense, because trigeminal nerves, as you see them on the images, vary something like between 20 and 8 millimeters. And that makes forward back. Secondly, have you angled the MR right? Because if you don't angle it right, you may shorten the appearance of the trigeminal nerve in the axial films. Thirdly, if you look at the spread of the isodoses, because one is concerned, obviously, of complications, you look at them, they don't reach any structure that could give a complication. They stay in the periphery of the pons, and all the important structures are deeper.
But for that famous 6 mm shot.
Sorry?
The famous 6 mm shot, which you defined using 4 and 8 millimeter.
There is an ongoing I don't think anybody uses 8 alone anymore, but the 4, the 6, and the rest of it, that's an ongoing debate. My preference personally would be for the 4. But I mean, you have a literature in which you go over 90, you get too many complications. And if you go under 70, you get too few successes. And it's like all treatments of trigeminal neuralgia, interventional treatments of trigeminal neuralgia, none of them last permanently. There's always recurrence with the passage of time.
That's very true. That's very true. We need to do it again and again.
Can I
Dr.
ask a
Salzer,
question,
please.
Dr. Ganz? The basement of radiosurgery sits on functional indications.
Yes.
Trigeminal neuralgia, thalamotomy for pain, etc. But how did his mind change to do radiosurgery for other lesions, for vestibular schwannoma or acoustic neuronoma in that time, or then AVM, meningioma, etc.? How did he change his mind to irradiate these kind of tumors that we do today so much?
Systematic, comprehensive explanation of what he did wasn't one of his strengths. A little bit I know about this, and it's gossip within the, as it were, within the family. But I mean, I've talked with Backlund and other people about this. Nobody quite knows what his thinking was, but the practicality was that a very expensive machine had been obtained with investment from important private investors, because that was one of his advantages. And suddenly it was going to be used to treat Parkinson's disease primarily. And then L-DOPA came along. And you know, neurologists, if they can stop a patient being sent to a neurosurgeon, then they've had a good day. And so the referrals dried up. And like anybody else with a very expensive piece of equipment, the use of which has been, as it were, sabotaged, you find something else to do with it. And the first patient was, I mean, this isn't written anywhere, this is gossip, but Backlund's patient was the first patient. And the interesting thing to me is, and you know how correct and formal the Swedes are. They chased off down to the manufacturing place with the patient in Lexell's Daimler, and he arrived late, and the whole thing was actually a mess. But they couldn't wait. Once the machine could be used, these formal, stiff Swedes, like schoolboys, rushed off to treat the first patient, who did, I think, quite well.
once he started practicing in radiosurgery, despite being a neurosurgeon, did he face any criticism from his contemporaries, other neurosurgeons across the world? How did he react to it?
Well, you have to put, this is an important question, has to be put in context. When he started doing stereotaxy, it was only a minority interest within the neurosurgical profession. And you can see the evidence of this because what's it called? The WFNS Neurosurgical Classics, the first one, had no mention of stereotaxy at all. Walker's History of Neurosurgery gives it about 4 lines. It was only in the second neurosurgical classics of neurosurgery from the WFNS that there is a section on stereotaxy, probably motivated by its use in radiosurgery. The point is, we're all neurosurgeons, and we all know that demonstration of our manual skill is part of our reputation is based on that, and probably indirectly our income. So that neurosurgical procedures that do not require any technical skill are less interesting.
So, how it's always a team game. He might be having some earlier medical physicists like Kutlaiden and some radiation oncologists in his team. Who are these people who actually helped him? Because it's always a cross training between different streams.
I'm going to do a little bit of self-advertisement. There is a letter coming to the British Journal of Neurosurgery on this very topic, which I've written, which will be coming out hopefully soon. When they started, the work was done between neurosurgeons and physicists. And they were both in Stockholm and in Berkeley. And the initial work was done with cyclotrons in both places. And the basic science was worked out with cyclotrons. Now, when the gamma knife was eventually designed and invented and built, the team consisted of neurosurgeon and physicist, and it went into a private home in Stockholm, the Sophiahemmet. When the second one came, that went into the Karolinska. I have been told that Lexell invited the head of the oncology unit to come and look at the instrument, and he absolutely refused to have anything to do with it. There was a total lack of cooperation with the radio oncologists. They wanted a LINAC, and he got the gamma knife. So it got off to a bad foot between the two professions.
But this is completely, I think it's still persisting because the radiation oncologists are still more towards the LINAC-based technologies. They are much more comfortable with that. And the neurosurgeons always look at the cobalt-based technologies, principally the gamma knife.
What happened was the first gamma knife meeting, Börje Larsen, Lexell first specified that this was not radiotherapy. This was a completely different use of radiation to destroy a piece of malfunctioning normal tissue. Always before, radiation was to treat pathology. And Börje Larsen, his physicist, specifically said in the proceedings of that first meeting that fractionation was not necessary. The WFNS, I think it could be either the American, finally came out with what was an accepted rule of how radiosurgery was to be performed, and the definition was up to 5 sessions. And a radiation oncologist had to be part of the team. Now, my own guess is you can't say this in public and you can't write it, but this is politics, not medicine. In 1993, at the third meeting in Stockholm, I got up and posed a question to the oncologists about whether fractionation was of value in this context, and their response was the same as it has been ever since. They refuse to answer the question.
Now, if you look at, please, Professor Selçuk.
Sir, can I ask you that when you were working in Bergen University, the third gamma knife, which is the first one out of Sweden, came to Bergen University, and as far as I know, that the model B means model Bergen. So in that time, you were there. So how you and the department decide to have this radiosurgery device in your center, and how you become a person who is interested with radiosurgery? Why you interested with radiosurgery in that time?
You're making it sound though I was in the position to make decisions. I wasn't. The department had been started up by a North Norwegian called Bed Jensen, and his health was failing, and he'd had a number of Swedish and Finnish people across who had been not terribly successful. And he finally got hold of Erik Olof Backlund. And Backlund came and accepted that he would come to Bergen on the condition that a gamma knife was installed in the center. They went down to the area next door to the radiotherapy department, and they were about to put it in when somebody discovered there was a big hole in the rock underneath they were going to put the gamma knife. So there was a delay until they got that sorted. And then finally, on the 16th of October, 1988, we treated our first patient. Now, I was happily operating aneurysms and thinking I was doing a jolly good job. And Backlund said he wanted me initially to be responsible for foreign patients because Norway is a conservative place and a large number of patients would not come anytime soon. We went to the meeting in Charlottesville, and there was a meeting there of all the then centers. And Backlund got up and said, they said, well, Bacchus, you're going to be in charge of Bergen. He said, no, it's Ganz. He didn't ask me. He just said there in the meeting, I was to be the center. And so I was. I didn't make it. I didn't decide it.
Are you happy with that decision?
This shows that
since I spent the rest of my life doing gamma knife, yes.
Yes, but it shows that he is a very, very clever person to find you to appoint with using gamma knife radiosurgery for the patients and about the education. It's showing his cleverness. Please, Manju.
I'm so happy that actually he was appointed and he could actually contribute so much to the radiosurgery, not only in history, but still he is contributing to that. But what I remember is that proton radiosurgery was much more in practice before gamma knife. So how did this transition happen and how did it change the landscape of the radiosurgery in your time?
The radiosurgery before the gamma knife was invented, the work in Sweden was almost entirely experimental at the Werner Institute. There were 1 or 2 patients treated, but proper records of them don't exist. In Berkeley, they finally got up to remember, this is before the CT, all they had were plain X-rays. And they decided that they could treat the pituitary fossa. And this was at a time when hypophysectomy for a wide variety of conditions was thought to be a useful treatment. They were going to use the Bragg peak, but they decided that they couldn't localize it well enough. So they used a crossover technique similar to the gamma knife, multiple beams. And they didn't actually move the beams. They moved the patient's head in relation to the beam, because obviously a cyclotron beam is not something you can easily rotate. So before the gamma knife, the treatments were exclusively in Berkeley, and they were hypophysectomies. The real proper clinical radiosurgery began in Stockholm in 1968.
As you have seen that from the analog scans to the CT and MRI based planning, how did this transition happen? And
well, when they started out, The only things that they could treat were what they could see. And what they could see were acoustics with air studies and AVMs. And they were having to treat them off skull x-rays because make the appropriate magnification and changes because of the geometry of the image of the x-rays. They also treated the pituitary fossa, where they couldn't see, and they were treating Cushing's disease, which was sensible because it's tiny and the tumors are going to be within the pituitary fossa. In the end, it never really worked very well compared with microsurgery, but they didn't have the technology. There was no hormone measurements. Radioimmunoassay didn't exist when they started doing this, and so they started with the AVMs and the acoustics. And one of the great mysteries, there's a paper by Norrain in 1983, when he was treating acoustics with way higher doses that we use today. They were simple shot treatments. So you could be a 14 or an 8. The dose to the facial nerve you wouldn't believe, but there were no serious facial nerve palsies. So it's a bit like the thing with the trigeminal neuralgia and the x-rays. This is rather difficult to explain, but that's what they recorded. The initial AVMs, Steiner was very strict about keeping them small. So they didn't really treat many that were over 2 centimeters in diameter. And they achieved a very high success rate. And the thing about Steiner was he was obsessional at nagging patients and their doctors to send post-treatment images so that he could have proper results. That's the images that they were using. The dose plan was a problem. In the very first cases, a physicist would sit down and work out what the dose plan should be with one single shot. Eventually, when we started in Bergen, they'd become advanced and they'd introduced Cooler, which by modern standards was a ghastly program. But firstly, you couldn't incorporate the images into the dose planning. You had the images and you placed it over a CT. You placed the dose plan on transparency over the CT to see if it matched. Not only, it was terribly slow calculating, so you had a way, you first did a quick calculation. So you could actually use the machine. And then you had a slow definitive calculation. You could only use 12 shots. Another thing about the B model, which was that it also was the first one to have 4, 8, 14 and 18 shots. They hadn't had the 18 before.
Now from Kula, you see the inverse planning and so much sophisticated gamma plan. So how do you see that this is actually shaping the future of radiosurgery? Are you in favor of forward plan? Is still in favor of a forward plan?
No. I mean, inverse dose planning, if it is properly demonstrated to do the job it's supposed to do, it has to be better. The only question I can think arising out of it is that as things stand, the tendency is for inverse dose planting to make a very large number of very small shots so that you get an absolutely perfect. The trouble with that is that the more shots you have and the smaller they are, the lower the dose rate. And the dose rate had incorrectly been used to record the dose rate in the beam rather than the dose being absorbed by the tissue. And that is now being examined with horribly complicated mathematical formulae I don't pretend to understand. But we still don't quite know the importance of dose rate, but it may well be a significant parameter, in which case inverse dose planning, you will have to take that into account.
So as you have brought the dose rate into question, I think we all have a fissures in understanding in the BET, because everything is now going from the isodose plans to the iso-BET plans, and there are so many papers who are actually coming over it. So how do you look at this controversy?
I am not a physicist or a mathematician. I can only qualitatively understand the fact that it does take two doses. You have an 18 and a 4. And the 18 affects the region of the 4, and the 4 affects the region of the 18, affects the intensity, the dose rate. And if you have multiple dosage, it becomes more complicated. The controversy is it's not medical, it's physical. And it is something for the physicists to put together, agree upon, and convince us that what they're doing is optimal.
Actually, as the machines are getting popular and there are more contenders in the radiosurgery, especially from the Linux side, so this question is getting more and more heated up in conferences because we are taking all these factors in the patient's outcome and the complication profile. So, and probably we have a better understanding of the BED with the gamma knife, but not with the other machines because there are some hot plants, cold plants, and then there is a time interval between the radiation delivery. So that's controversy is probably going to heat up in the future.
Well, I think there is a way to avoid it. I also think it won't happen. When the gamma knife started, the Lexell made it forbidden to treat anything malignant. And the reason for that was he didn't want the complications of the disease mixed up with the complications of the treatment. So only benign. Subsequently, after a while, metastases came to be treated. And they have a number of problems. Firstly, they're the commonest tumor. So there's lots of them. And one of the unavoidable disadvantages is if you are going to buy a very expensive machine, you need to have patients to pay off the investment. And metastases make that easier. Gamma Plan with perfection has made it much easier to treat multiple lesions in one go without or the wretched changing the helmets or other complications prior to that. But the point is this. When they started treating METs, the Linacs of the day, including CyberKnife, were not as good. Today, the Linacs are good enough to treat METs. And there are two more advantages. Firstly, they're quicker. So the patient has less time in the machine. And I can quote from the UK. In the UK, I think we have 7 gamma knives. There are over 350 Linacs. So for any patient who is a dying patient when all is said and done, the journey from home to treatment has to be shorter if it's to a Linac center. And finally, on Lexell's own principle, it's not technology, it's the clinician which decides which treatment you use. And the oncologist not only knows how to treat the METs, he knows how to treat the primary tumor. So my suggestion would be a gradual movement of metastases solely to the radiation oncologist treatment in Linacs, and let the gamma knife be used for what it was originally invented, a surgical tool. I don't think it'll happen, but I think that's sensible.
With this famous line, a fool with a tool is still a fool. So the man sitting behind the machine is more important than the machine itself.
Yes.
Probably Professor Salzo wants to speak something on it.
Dear sir, can I ask you, in a book from Laurent Lexell, he wrote that when he was talking to his dad, Lars Lexell, in a dinner in the beginning of 80s, he asked him how much gamma knife device in that time, of course, how much gamma knife device in the world we can sell or the world needs. And Lars Lexell said that the 3 gamma knives is enough for all world. But today, as you said that, there are hundreds of gamma knives, hundreds of cyber knives, Linux systems, Zapix systems, a lot of radiosurgery devices in the world, and millions of patients have been treated since that time. And in the beginning, in many years ago, when I was a young radiosurgeon, the neurosurgery specialists, our friends, seeing the radiosurgery as a threat for neurosurgery. What is your thought about this? Radiosurgery is a threat for neurosurgery or as a supplement for neurosurgery? What's your opinion?
Well, you can either think of this as either or both and it's both and. Where you draw the line, there was a fairly celebrated squabble between Steiner and Bennett Stein about treating thalamic AVMs, and Stein's results with thalamic AVMs were superb. But one has to remember that people like Stein or Sami, who else has 3,000 acoustics? Nobody else in a lifetime is going to get 3,000 acoustics. So the experience of the super specialized center is not relevant for the normal center. You know, 100 or 2 would probably be a good lifetime's experience with acoustics. But you're never going to, a person like Sami will work out an optimal technique, which the rest of us can share. But this experience, saying that his experience is relevant to other people's at the time he's working, doesn't make sense. So this is always going to be a source of debate related to the individuals, their talents, and not least their referral base.
I think this always remains, if you go with the radiosurgery for vestibular schwannoma and microsurgery for vestibular schwannoma, and a very important thing which I notice is that whenever we talk about the complications, people start quoting the literature and then they quote the complications of Sami and all these giants of the vestibular schwannoma surgery, and then they compare it with the radiosurgery. So it's not a very fair competition. People have to give their own complication rate and then they should quote with the complication rate with the radiosurgery. It's very individualistic data, and on which, because that particular person is going to operate on somebody, so it's his data which needs to be quoted on.
I actually had a correspondence with Sami on this very topic, because he published back in whenever it was, the success of his latest 200 cases. And I said, that's fine, but radiosurgery, a facial nerve palsy after radiosurgery, is basically unacceptable. A facial nerve palsy after any acoustic that's more than 2.5 to 3 centimeters, at least partial, temporary, is a risk. And today, in fact, what's his name? That famous London, Ontario, Charlie Drake. Charlie Drake was all in favor of doing intracapsular acoustics because of the risk of damage to the facial nerve. And with the modern imaging, not like in Cushing's time, you could see what was happening. So if it started to recur, you could go back and do it again. Now, Drake didn't like radiosurgery, but it seems increasingly sensible to do an intracapsular removal or parts of the tumor which do not affect the facial nerve, and then treat what is left with radiosurgery. And the beauty of this is, if you core out an acoustic, it collapses. So after the surgery, it's smaller. Regrettably, that doesn't happen with many meningiomas, which you just have a big thing with a hole in it. So that both and remains to me, I think, the sensible way of doing it. I know the group in Bergen is at pains to say that observation of very small tumors is better than doing radiosurgery of very small tumors, but actually their statistics are a bit iffy.
Dr. Mahip wants to ask a question. Please, Dr. Mahip, you can ask.
Yeah, thank you. Professor Ganz, we know each other for a very long time. And if you remember, when you visited Fujieda, where I was training for Gamma Knife in 1996, there are many patients of metastasis. Professor Hirai and Professor Yamamoto, they used to do many metastases, 20 metastases, 40 metastases. And they means they're untiring, means they continue to do it, and they were very happy with that. And at that time, they told me that yes, most of the world don't do it, but we try to do it. And now it appears that many other countries and other people are start doing multiple metastasis. So do you think it is still worth treating multiple metastasis instead of whole brain radiation? And we should continue to do like in Fujieda, we had a protocol that the patient is called every 6 weeks and take a fresh MRI, and whatever new has come, that is treated again. So if we start with 20 metastases, ultimately ending up to maybe 70, 80, even 100 metastases. So every 6 weeks, the patient is treated. In India, we found problem that patient don't survive. If they survive, now they are surviving with chemotherapy. We could not get that amount of metastasis patients to be treated. What is your opinion?
Well, firstly, I had a conversation with the late Professor Oya on the practice of treating over 20 metastases. And his comment was, it isn't clear who is the crazier, the patient or the surgeon.
No, Professor, it's called metastasis. In Japanese, it means crazy.
There's an importance. Firstly, whole brain radiotherapy arose at a time when you couldn't image the brain. It was the only available treatment. So you treated the whole brain. I don't honestly think that there's much indication for that. If you're going to treat metastases, you treat the individual tumors and keep the dose to the normal brain down. But there's a much more important statistic. Very roughly, there's something like a 90% tumor control after brain met radiosurgery. The radiated 90% success. There is roughly a 50% mortality at 1 year. But most importantly, 80% of the mortality is for extracerebral reasons. That's why the disease should be in the hands of the radiation oncologists. And it is, I think, for them to decide how to treat the brain in relation to what's going on in the rest of the body. It's become much more complicated. There are pharmacological and or other sort immunological things that you can add to the treatment, which needs to be taken into the balance of what's happening in the whole body. So I think that the number of mets you're treating is not really a major issue. The total volume of the number of mets you're treating is a matter of an issue. The number of mets is a matter more of convenience. It's more complicated, takes more time. But my own view is is to bear in mind that what kills these patients is not the brain mets. It's the systemic disease.
Yeah.
But as we have so much data here now for that, it gives us such a good neurocognitive outcome, and it's a relatively shorter duration treatment so that the patient can continue with their systemic treatment. I think radiosurgery should be given a preference, and there is a lot more data now over the metastasis with giving the wonderful results even for the large volume metastasis.
I'm not saying that you shouldn't use radiosurgery to treat metastases. I'm just saying the gamma knife shouldn't. It should be in the hands of radiation oncologists who treat the entire disease using a modern LINAC.
Few cancers have a very good survival, like breast cancer treated in time with surgery, radiation, everything, may live 20 years. And if they're given whole brain radiation...
I'm going to interrupt you. This is true, but only for a minority of patients.
Yeah.
The 50%, 90% figures, this is for big series.
What I'm saying is that if patient survives from cancer, but at the same time he has received a whole brain and his cognitive system has gone down, then means total futile. at one stage that patient is totally not workable, although he's alive.
Don't use the whole brain radiotherapy.
Yeah.
As I say, my argument is not against radiosurgery. It's about the allocation of which radiosurgery resource you use. And I've been involved in the gamma knife, as you gentlemen know, most of my professional life. And I'm still standing up here and saying, now we have a decent LINAC, and there's lots of them, and it's a shorter journey, and the professional competence is greater. It should go to the oncologist with their LINAC. And we could go back to treating the sort of conditions we should be treating with a surgical tool.
So, sir, can I ask you, you saw a lot of neurosurgeons, radiation oncologists, and medical physicists in their early career life. And today, a lot of radiation oncologists, neurosurgeons, and medical physicists want to be experienced on radiosurgery. What would you recommend them to do to become an experienced and clever user for radiosurgery? Any device, not the device specific thing. What would you recommend?
Well, the training is inevitably device specific. You'll either go to a LINAC center or a CyberKnife center or whatever. The trouble for the physicist is that the work as a radiosurgery physicist isn't enough. It's not. He has more time than so. One really needs to find a way of combining either with research or with some other clinical activity. So because once he's qualified for doing radiosurgery, he needs more to have a decent job.
Professor Ganz, if Lars Lexel were alive today, what aspect of the modern radiosurgery would surprise him the most, in your opinion?
Whole brain, whole body.
Whole body SRS.
Whole body radiosurgery. He would never have considered it.
Why so?
He was a neurosurgeon totally concerned with neurosurgery and brain problems. And whole body radiosurgery is relatively modern, and I know little about it except that it's effective, it would seem, for example, prostate cancer. But the fact remains that it would have been outside his range of experience and knowledge.
So
what do you think? You have an idea about this? What is
no. I think means one of the things is the metastasis, because it was completely a strict no from his part, and then he sees that not only the metastasis is the number one indication throughout the world, and there is so much hypofractionation for the metastasis. So that thing might have surprised him completely, apart from the technological advancements that the radiosurgery has gone through.
You do know there isn't a single article which clearly demonstrates that hypofractionation is beneficial. It's used because there isn't one. I've looked into this recently. However, there can't be one. And the reason is there are so many parameters involved in the treatment of METs that you can't get one paper to compare with another. So it's almost impossible, I would say, to you make a decision. But my own personal preference would be fractionation no, staging yes. Because staging, for the most part, because they're malignant tumors, they react quickly. So that if you give one dose, whatever time afterwards, it will have shrunk, which makes the treatment of what is left much more effective.
The principle behind the adaptive radiosurgery. The principle behind the adaptive radiosurgery.
That's a term I didn't know. That's a new one on me.
So, Professor Ganz, I just want to just say something. That after 27 years doing gamma knife, when my center stopped, I shifted to CyberKnife. And it was a shock for me how the system is run. I mean, the oncologist just prescribes the dose, and then everything is on the physicist's hand. and finally some junior confirms, and they started giving radiation. So the first month, it was so difficult for me to explain to them that this is surgery. This is not radiotherapy. You can't just leave it like that. Means spending 1 hour and 1.5 hours sitting with physicist, he was also surprised how many changes I have to make to come it suitable for my head that, okay, this plan may be good. But now they have understood. Problem is that nobody guides these people in so many Linux centers how it has to be done. It is not the machine. It is the physician who is treating. It is important that he does not let it go for radiation unless until he is sure that yes, radiation is not going to harm the patient, or how much safety limit he has kept and how much radiation is giving the tumor. But people just leave it like that. That's why we feel the difference between the some centers and other centers. That means LINAC, and it's not about the machine. It is more about the person. If he understands radiosurgery and he can give time to the planning.
Let me tell you that I was recently, the paper the letter I've just sent, has been looking at this literature. And firstly, one of the weaknesses on when you're talking about METs is there's a tendency to put in a series which has all technologies, LINAC, Gamma Knife, CyberKnife, as though they were the same. They're not. The second thing is, in an awful lot of the LINAC papers, important parameters like dose and volume are missing. That is one of the advantages of all the development of the Gamma Knife. The Gamma plan with all its different parameters is way ahead of anything else.
Yeah, that's sure.
Thanks so much. And Professor Seljuk, do you have any more questions to our esteemed speaker?
No. Thank you so much. It was a very delightful 1 hour with you, dear sir. And it was very nice to see you in a healthy position. And of course, we would like to see you in our meeting in next year in Istanbul. And thank you so much for your nice words and all these explanations. Thank you.
I just have one last question to you. Is there any more book in process so we can read it in some more time?
On the 16th of August, there is a book not on neurosurgery. It's a history of how surgeons coped with the pain of surgery before anesthetic.
Pretty interesting.
And that is coming out in August.
We recently just had. I'm eagerly waiting for your book, and thank you for sharing your some books with me on your email. On the email, they have really helped me a lot. We recently have an autobiography of David Lunsford. It's a brain surgeon without a scalpel.
I've seen it. Yes.
I'm reading it, still reading it in the initial chapters, finding it pretty interesting. I think the journey has not changed over the years because the same sort of skepticism you have to face once you start showing your interest in radiosurgery, despite being a neurosurgeon. But most of the neurosurgeons now are actually able to balance both the knives with the radiosurgery and neurosurgery. And probably that's because of a mixed philosophy here.
I'd like to make a comment made by the Nobel Prize winner Max Planck. Now, this is a paraphrase, not the actual quote, but he said, when you invent something new, you will not convince your colleagues. They will die off, and their students and the youngsters you've taught will accept it.
I think that's very true. That happened with Gamma Knife. And in the initial part of the talk, you told that other indications came into practice because there were not many patients. So we tried to extrapolate our radiosurgical experience. Probably that's going to happen with the other upcoming technologies like MRG, FUS. Started it only with the essential tremor, and now they are trying their hand in different pathologies, malignant, benign, functional, everything. So probably that's something which we would see in next coming decades. So is there any question from our audience? Else we'll just have we'll close this webinar. There are a couple of comments, and everybody has actually found this very interesting going into the history. So on behalf of the WFNS Radiosurgery Committee, I extend my sincere gratitude to Professor Ganz for this enlightening session. He took his time. And today's discussion reminds us that radiosurgery is not just a technology, it's a philosophy of precision, innovation, and patient-centric care. Thank you all for joining us. We look forward to seeing you in the next webinar. And these webinars would be, in some time, they would be available on the WFNS YouTube channel. So you can see the archives. And based on this webinar, there would be a chapter written by the Professor Ganz. He's the authority on history of radiosurgery at present. Thank you so much, Professor Ganz. Thank you, Professor Salzo, Professor Mahib, and our attendees.
Thank you.
Thank you very
Thank
much.
you to all.
Thank you.
Thank you. Thank you all.
Thank you.
Bye bye. Bye bye.
Thank you.